So we see this quite frequently where people, for example, decide to go overseas to see their relatives. And we now tell people to really, we've got a form which tells people, please discuss with us if you're planning a trip, because we can work around this, you know. We can try and do an injection just before you leave. Don't stay away 6 months, but, you know, at least try to work with you to try and reduce the interval that you're without the drug. Or even try to work a letter for someone overseas to do it, if you're going to be away long enough. The second issue is, we find this happens frequently, is when a patient in this older age group gets other problems. For example, their knees start to fail, or they get a lot of pain from arthritis in the knee or the hip, or other conditions, comorbidities we call them. So when people need to go into hospital for a knee replacement, then often it's out of sync with their eye treatment and they forget about the eye treatment. They miss an appointment and then actually forget to come back after they might have a difficulty recovering. So we want to work with patients before they have their knee replacement to maybe do an injection just before, to remind them that, well, we can see you in a wheelchair. It doesn't matter, you know, if you can't walk. It's critical to come back in. There's no point coming back and having a knee that's pain-free and losing the vision in that eye you were having treated. You know, and it happens that quickly. Once people go beyond 10, 12, 16 weeks, then the frequency of the disease recurring is quite high. And particularly if people get a recurrence where they get a large hemorrhage at the centre, even though we might restart treatment, we probably won't bring it back to the level they had. So it's really important that we don't have prolonged absences from therapy, and that people understand this treatment needs to be continued because it only lasts a certain time, and that time is a bit variable depending on different patients. It's not the same in each patient. And so once we've got a person to an interval that's appropriate for them, we need to keep them at that interval. And if they can't make it, we've got to try and work out a way of them getting the therapy, or impress on people that this is something you can't stop. And you know, so all of those other elective things we can work around. Now, if someone goes into hospital for a heart attack, well, we can't. That's a non-elective, urgent thing, and we can't avoid that. But, you know, we can, a lot of the elective things we can work around, and holidays and absences for other reasons we can work out. So, you know, it actually requires people to think about this ahead of time, that this is a long therapy that they're embarking on. Now, there are some other reasons that people stop, and it's worth mentioning some of them. One is the sort of fatigue that people get from having injections time after time. Now, one of the things we can do as eye doctors is make it comfortable. We should be able to do it without causing much discomfort. Now, occasionally we cause it discomfort, but we should be able to do it without causing much discomfort. So if a person tells me, oh boy, this is hurting like hell, you know, which is very uncommon, you know, then I'll really make sure that we work around that and try to do it in a way that isn't uncomfortable and that doesn't put people off. The second issue is that people often are concerned that their vision is still poor and they haven't improved much, or that the improvement has stopped. So they think, well, is there any point keeping going? Well, actually, there is, because we're holding the level that it is now, even if it might be a reduced level, by keeping on with the treatment. So it's important for people to understand that it will go off further if we stop, and they will lose the remaining vision. We might be only retaining a certain amount of vision in that treated eye, but it's worth doing that, particularly if it's their best eye, and not to stop it. Now, there are a few circumstances where we can stop. If someone's got a lot of atrophy, a lot of loss of cells, there are some cases we can work with patients and consider stopping, extending out to a long period and then stopping. But there aren't so many of them, and most people need to think that they're going to be on this for macular degeneration lifelong. For diabetes, it's completely different. Diabetes is a finite period of time. For most people, it's about 12 months to 18 months. Some people it can be less than that. Some people extend into the second, third year. But mostly it's a defined period of time with an extension and then a break and see how it goes, and then retreatment if needed. Whereas macular degeneration, it's consistent treatment at an interval that is worked out over time.